you know to understand what is happening within the abdomen. Even in case of acute intestinal obstruction, either due to a gallstone within the gut, or a fecalith, or a clump of worms. And outside the lumen, in the wall there could be tubercular stricture. And outside the lumen, there could be additional abnormal bands causing volvulus and causes within the chest wall, that is the diaphragmatic or the lobar pneumonia, neuralgia due to herpes zoster or tabes dorsalis. All these can put a case, present the case as an acute abdomen. And you need to take the history of it. First, you should take the history of the case. Then follow as per the organ you have diagnosed to be disease. You have to follow the peritoneum as per the diagnosis you have made, right? Now there is a history of pain around the umbilicus. The pain started around the umbilicus with vomiting, temperature, pain, vomiting and temperature. And later on, this pain shifts to the right iliac fossa. This is a definite diagnosis of acute appendicitis. Understood? Now, following this episode, what happened? There is a formation of lump in the right iliac fossa. And the acute symptoms will pass away when there is a perforation. When there is a perforation, at first the condition of the patient improves. Later on, due to generalized peritonitis, there will be paralytic ileus and a silent abdomen. Got my point? When there is a generalized peritonitis due to perforation of the appendicular lump, initially the pain reduces. Later on, due to generalized peritonitis, there will be silent abdomen due to paralytic toxic ileus. There will be no movement of the gut, and you can auscultate that the abdomen is silent. Similarly, in retrocecal appendicitis and pelvic appendicitis, there are some different signs and symptoms. You will test by the Rovsing sign. Rovsing signs mean you press the left side of the abdomen and the pain will be shifted to the right iliac fossa. This is called Rovsing sign. Similarly, you will test for Schwartz test and obturator test to understand whether it is a pelvic or is a retrocecal appendix. Got my point? Now, the signs that you look for, that is a pain and tenderness in the right iliac fossa, that is in the Sherren's triangle. Write down the spelling, Sherren, Sherren, Sherren apostrophe S. This is the Sherren's triangle. There will be hyperesthesia in this Sherren's triangle, that is from the umbilicus to the symphysis pubis to the right to the anterosuperior iliac spine. This triangle is called Sherren's triangle, and there will be hyperesthesia at this triangle. And when there is peritonitis, first there will be local guarding. Remember, the parietal layer of the peritoneum is innervated by the somatic nerves. Parietal layer of the peritoneum is innervated by the somatic nerve, and the visceral layer is innervated by the autonomic nerve. So the pain at first is dull and vague around the umbilicus. Later, as the peritonitis, local peritonitis sets in, the pain the pain transmitted by the somatic nerve will locate the pain area in the McBurney's point. That is, it is a localized pain. Similarly, in splenic rupture also, there is Kehr signs, K-E-H-R apostrophe S. Kehr signs mean there will be pain on the tip of the shoulder due to the blood irritating ruptured spleen irritating the undersurface of the diaphragm, and the pain is referred to the left tip of the shoulder, right? So in case of when you diagnose, it is a case of acute appendicitis. Simultaneously, you should also understand where the organ is and what is the peritoneal reflection over that organ. Similarly, in acute cholecystitis, acute intersusception, in acute rupture of the malarial spleen, in volvulus with additional bands of peritoneum causing the twist in case of volvulus. In all cases, you should try to understand what is the condition of the peritoneum. That will give you, number one, the correct diagnosis, and number two, correct progression of the disease. It is not important to diagnose anything without knowing the progression of the disease. And to know the progression of the disease, you know the condition of the peritoneum, where it is and how it is getting reflected around the zone of disease zone, right? Now at first you take a at first as the peritoneal fold from the ventral wall of the abdomen that falls on the liver as the falciform ligament. The part and the other is the coronary ligament. From the liver to the stomach, this part is the lienorenal. This part comes from the ventral mesogastrium. All right, and the posterior aspect, that is the gastrosplenic ligament and the lienorenal ligament, together with the a part that extends behind the stomach, that forms the dorsal mesogastrium, and within the left layer of dorsal mesogastrium, the spleen develops, giving rise to the gastrosplenic ligament and the lienorenal ligament. And this part of the linear that goes beyond the stomach will give rise to the formation of the rudimentary greater omentum afterwards. Right? Now you must try and practice the three cross-sectional layers of the peritoneum, horizontal, that is at the level above the epiploic foramen, at the level of the epiploic foramen, and at the level between the epiploic foramen and the transverse colon. You should practice the 3 layers of drawing, because this comes in the examination. Draw a level diagram of the peritoneal extension, horizontal extension, say at the level of epiploic foramen or below the epiploic foramen or above the epiploic foramen. This comes in the examination. So you should practice it. All right. Now, 1, 2, 3, 4, these 4 layers denote the layers of the greater omentum. All right. The part only above is a little broken. All right. I couldn't make it fall on the caudate lobe and the caudate process of liver. That layer should fall on the caudate lobe and the caudate process of liver, thereby completing the laser sac. Right. The fourth layer that comes to the anterior border of the pancreas. From there it encloses the transverse colon. From there it goes downwards, all right, to encircle the gut, that is the mesentery, and forming the, in the lower part, forming the sigmoid mesocolon. Right. Then it goes to the pelvic peritoneal cavity, as I have shown you, onto the anterior and lateral aspect of the rectum, and the mid part on the anterior part of the rectum. From there it goes to the posterior surface of the base of the base of the urinary bladder, covering the seminal vesicle and the upper part of vas deferens, and from there it covers the superior surface of the bladder and then to the anterior abdominal. This was the reflection I have drawn in the last day. All right. So now you need to know, number one, in the early life, early childhood, the extent of the 2 layers of the greater omentum is quite below the, up to the or below the umbilicus. But later on, by zygosis, the extension of the laser sac on the lower aspect becomes closed above. So the greater omentum is not of that much lengthy in case of an adult person. Right. Now you need to know 3 things more. That is the transverse mesocolon. Where is the root of the transverse mesocolon? Number 2, the mesentery and the sigmoid mesocolon. Root of the mesentery is from the duodenojejunal flexure to the ileocecal junction. All right. That is from the level of the L2 to the sacroiliac joint. This is the root of the mesentery. Behind this root of the mesentery, there are the ureter, psoas major muscle, genitofemoral nerve. All these are behind the root of the mesentery. Right. Now you see the transverse mesocolon. Transverse mesocolon, the 2 layers falls on the anterior border of the pancreas. All right. From there, one layer goes to the anterior superior surface and another layer goes to the inferior surface of the pancreas. Understood? This is the root of the transverse colon. Transverse mesocolon, root of the transverse mesocolon. Transverse colon, it contains the transverse colon, the arteries of middle colic artery and the ascending branches of middle colic artery. That gives rise to the arteries of Drummond along the fan-shaped mesentery. So mesentery is a 20 feet long fan-shaped organ covering the peritoneally covering the ileum and jejunum up to the third part of duodenojejunal flexure. Got my point? From the ileocecal junction to the duodenojejunal flexure. This is the extension of the mesentery, and this gives rise to the fan-shaped extension covering the small gut. And within this, there are branches of middle colic vessels. From there, the branches creates the small arcades in the jejunum, the larger arcade in the ileum. That you know, isn't it? That you know. And the fat within the jejunal arcade is less, and that in the ileal arcade. This is thick. All right. ठीक है